Hello everyone. In today's lecture we are going to be talking about depression and antidepressant drugs. So what depression is, it is actually a feeling of sadness and hopelessness. In this condition, the patient actually feel inability to experience any pleasure. In any of his or her usual activities, and he can also have disturbance in sleep cycle or sleep patterns. He also experienced loss of appetite or change in appetite behavior. He also feel loss of energy, and there can be also presence of some suicidal thoughts. If we talk about the pathophysiology of depression, what actually happened that there is decrease in the concentration or production of nor-epinephrine or serotonin. So there is decrease in the concentration of nor-epinephrine or serotonin in brain, which actually result into depression. So this thing actually lead to a theory which is called as biogenic amine theory. According to this theory, it is said that depression is due to deficiency of these two monoamines at certain site of brain. But this theory is actually overly simplified, because after taking antidepressant drug, this thing is immediately recovered, but therapeutic response of the patient takes over several weeks. So it is suggested that reuptake of these neurotransmitters is only the initial effect of the drugs, but it is not directly responsible for antidepressant effects. So this bioamine theory is actually overly simplified, because reuptake of these neurotransmitters is actually immediately been recovered by antidepressant drug, but the therapeutic response of the patient for antidepressant effect is not directly stimulated. So what antidepressant drugs do is that they potentiate the effect of nor-epinephrine or serotonin directly or indirectly in brain, which in turn cause the increase in the presence of nor-epinephrine or serotonin in brain, which result into antidepressant effect. So this is how antidepressant drugs actually work. So we have different classes of antidepressant drugs, which are SSRIs, which stand for selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors. They actually inhibit the reuptake of serotonin neurotransmitter, and which result in increase in the concentration of serotonin in synaptic cleft. And the next class include serotonin nor-epinephrine reuptake inhibitors. They inhibit the reuptake of both serotonin and epinephrine, nor-epinephrine, and in this way there is increase in the concentration of these neurotransmitters in the synaptic cleft, which cause increase in the response of these neurotransmitters. And the next class is atypical antidepressants. And the fourth one is TCAs, which stand for Tricyclic Antidepressants. And the next one is monoamine oxidase inhibitors, which are known as MAOIs. So they actually inhibit the enzyme present for the degradation of serotonin or nor-epinephrine. So in this way they will increase the concentration of these neurotransmitter for the cellular responses. Tricyclic antidepressants are actually also called as TCAs, and these have similar activity as that of SNRIs. That is, they inhibit the reuptake of serotonin and nor-epinephrine. So they inhibit the reuptake of these two neurotransmitters. In this way, what happens is that there is increase in the concentration of these two neurotransmitters, and there is increase in the cellular responses of these neurotransmitters. In this way, they show their antidepressant effect. But only difference between tricyclic antidepressant and SNRI is that tricyclic antidepressants have much severe kind of adverse effect than that of SNRIs. So tricyclic antidepressants include tertiary amines and secondary amines. If we talk about the tertiary amines, it include drugs like imipramine, and it is a prototype drug of tricyclic antidepressants. Cloipramine, amitriptyline, and doxepin. Trimipramine. If we talk about the secondary amine, it includes agents like desipramine, nortriptyline, and protriptyline. These agents are included in secondary amine. There are some tetracyclic antidepressants which are also being included in tricyclic antidepressants. These tetracyclic antidepressants are maprotiline, amoxapine. If we talk about the mechanism of action of these tricyclic antidepressants, as I have told you earlier, that they inhibit the reuptake transporters which are actually present on the presynaptic nerve terminals. In this way, they increase the response of norepinephrine and serotonin neurotransmitters. So TCAs along with a tetracyclic, that is amoxapine, these are potent inhibitors of serotonin and norepinephrine reuptake transporters. whereas tetracycline, that is maprotiline, and a secondary amine, that is desipramine. These two are relatively selective inhibitors of nor-epinephrine reuptake. Not only this, TCAs also block many other receptors like alpha-adrenergic and histaminic receptors, muscarinic, as well as serotonergic receptors. In this way, they show their adverse effects, because most of the adverse effects of TCAs are because of these blockage. Otherwise, no therapeutic use or benefit has been declared because of this blockage of these receptors by TCAs. Only adverse effects are being shown because of this blockage of these receptors. If we talk about amoxapine, it not only inhibit these receptors, but it also inhibit 5-HT2 and dopamine 2 receptor. If we talk about the uses of these tricyclic antidepressants, so they can be used to treat moderate to severe kind of depression. Other than that, it can also be used to treat panic attacks or panic disorder. Tertiary amine from tricyclic antidepressant, that is imipramine, is also used for bedwetting, but it is largely replaced by newer agents which have lesser kind of adverse effects. In children older than 6 years, in them it is used for controlling bedwetting. TCAs are also being used for severe kind of pain like migraine, headaches, and other chronic pain syndrome. For example, neuropathic pain. Neuropathic pain is very severe kind of pain and cannot be cured, so for treating such kind of pain it can be used. Low doses of these tricyclic antidepressants are also used to treat insomnia. Tricyclics antidepressants actually elevate mood and improve mental alertness and increase physical activity of the patient. If we talk about the pharmacokinetics of TCAs, TCAs are well absorbed orally, and after oral administration they can easily go into CNS because of their lipophilic nature, and they are widely distributed throughout the body. But they have variable first pass metabolism in the liver. Therefore, they have low and inconsistent bioavailability. Also, because of the drugs which induce or inhibit CYP450 isozyme can also alter the effect of TCAs. After metabolism, TCAs are being excreted out through the body in the form of inactivate metabolites via kidney through urine. If we talk about the adverse effects which are being caused by the tricyclic antidepressant, so as I have told you earlier that tricyclic antidepressant also block various other receptors such as muscarinic receptor. So when they block muscarinic receptor, what actually happen is that dryness of mouth, xerostomia, blurred vision, urinary retention, tachycardia. Other than that, there is cause of constipation, and it can also aggravate angle-closure glaucoma, and these agents can also cause life-threatening arrhythmias if there is overdoses of tricyclic antidepressants. If we talk about the blockage of alpha adrenergic receptors by the tricyclic antidepressants, there will be cause of orthostatic hypotension. This is the kind of hypotension which is because of the posture. And if we talk about the blockage of histamine receptor, H1 receptors, when these receptors are being blocked, what happens? That there is cause of sedation. Tricyclic antidepressants have a common adverse effect, which is weight gain. Sexual dysfunction is also an adverse effect of tricyclic antidepressant, but it happens in minority of patients and its incidence is much lower than that of SSRIs, which is selective serotonin reuptake inhibitors. So there is less incidence of sexual dysfunction. TCAs, like any other antidepressant, should be cautiously used in patients having bipolar disorder, because in bipolar disorder there is two states of the patient. There is presence of two states of patient, that is manic state and depressed state. Even if the patient is having a depressed state, and if he take these or any other antidepressant, it can cause the switch to manic behavior. So in such patient, tricyclic antidepressants or any other antidepressant should be cautiously used. Tricyclic antidepressants can actually worsen some medical conditions such as benign prostatic hyperplasia or epilepsy. Or pre-existing arrhythmias, because it has adverse effect of causing arrhythmias. So if a patient is already having arrhythmia, it will worsen the condition of the patient. So in such patient, tricyclic antidepressant should be avoided. And overall, if we talk about tricyclic antidepressant, they have very narrow therapeutic index, that there is very little amount of drug which can be used for therapeutic purpose, after which it will be converted into lethal dose. So we should prescribe tricyclic antidepressant very cautiously so that it do not cause any harm to the patient. So this was all about tricyclic antidepressants. If you want to learn about other kind of antidepressants, you can go to my channel, and over there you can find other types of antidepressants which are being used medically. So if you have any question related to the topic, let me know in the comment section below. And thank you for watching my videos.